Hi there. Welcome once again to the program, Your Doctor in COVID. I'm Dr. Mahendra Carpen, Head of Medical Services and Cardiology at the Georgetown Public Hospital Corporation. Today we continue our conversations around the COVID-19 pandemic. And remember, if you have questions, you may send us WhatsApp messages to 620-6275. Or you may send an email to docandcovid@gmail.com. Today, like every day else, I have started out by wearing my mask, properly covering my nose and mouth. But for the rest of our conversation, I will take it off. And the correct way to take it off, of course, is to use the straps and remove it. There is no one here with me in studio, so I'm not putting anyone at risk, and therefore I myself am not at risk of picking up COVID-19 from anyone around me. So we continue to see cases positively identified and tested in Guyana, and this has been since March of 2020, and I suspect this will go on way into 2021. I wanted to bring you up to speed with some statistics as it relates to our experience in Guyana and the Georgetown Public Hospital as it relates to number of positive cases, deaths, etc. So let us look first at the number of cases in the country as of the 27th of November 2020. At the time of preparation for this presentation or this conversation, Guyana would have recorded 5,310 total positive cases. Those are the cases that are recorded, that are known, and we have evidence that these persons are actually in Guyana or were in Guyana. There is a feeling that this does not represent the total number of positive cases. And in fact, in other countries, other more established societies, whatever their number of positive cases are, they would have multiplied it by as much as 3 to 6 times to estimate what the total number in the country is. But for our purposes, what we have evidence of is 5,310. Out of those positively identified cases, we have had an unfortunate number of 149 persons who would have died. That represents a case fatality rate of about 2.8%. Case fatality rates are essentially calculated as the percentage of persons who would have died from the total number who are known to be infected. Across the world, the WHO and the CDC and all the authorities have identified that COVID-19 case fatality rate is somewhere between 2 to 3% on average. However, there are countries, some far more advanced technologically and financially than our own Guyana, that have case fatality rates much higher, 5, 6, 7%, and that's a concern. And there are various factors that are responsible for the discrepancies in numbers. We know for sure that older persons are more susceptible to the COVID-19 infection and mortality. And in societies where they have a lot more older persons and persons in nursing homes and long-term assisted care, assisted living facilities, they have a higher case fatality rate. When you compare our expected life expectancy in Guyana versus those other countries, we could understand why some of their fatality rates are a little bit higher. Of all our known cases of 5,310, we have also had 4,272 persons who are classified as having recovered from COVID-19 infection. So I wanted to bring that to you in perspective to understand what our overall known numbers are like in the Republic of Guyana. In the Georgetown Public Hospital Corporation, we see all of the really sick patients who are able to be transferred there for advanced care. And so far, in the COVID ICU at the Georgetown Public Hospital, we would have had 253 admissions. That's the COVID ICU at the Georgetown Public Hospital as of the 27th of November 2020. Since that time, that I believe was a couple days ago, we would have moved our COVID treatment facility, even for the ICU level patients, over to the new Ocean View COVID hospital. And that took some effort, but we are pleased that the transition has been made, and all of these patients, even the really sick ones, have been able to go over there and are receiving the appropriate care that they deserve. So we would have had, at last census in the Georgetown Hospital, a total of 253 cases admitted to the COVID ICU, of which 241 were actually confirmed positive. You would notice that's a difference of about 12 that were not positive. And we believe that those persons had all the signs and symptoms of COVID-19, but they would have been what we call false negative results, where everything added up except the actual test. And that is a well-known, well-recognized phenomenon in the field of infectious disease or medicine in general, when we tend to have a bias towards our clinical judgment, and even if the tests show a different result, we often go with our clinical assessment of patient. False negatives are very well recognized and form a part of the conversation and evaluation and treatment of these COVID-19 patients. In the Georgetown Hospital, we would have had a total of 104 deaths. In the ICU, the COVID ICU, there were 63. In the emergency room, there were 20 deaths. In the transition ward, there were 17, and the open ward, 4. So I want to make 2 points about this. We have 20 persons who would have died in the emergency room. The average stay in the emergency room is generally less than 24 hours. So it means that those persons would have come to the hospital and died within a 24-hour period. And that's very unfortunate, because the meaning behind that is to recognize that those persons would have been quite sick at home for some time before actually reaching to the hospital. So by the time they get to the hospital, they did not stabilize and did not make it up to the actual COVID ICU, but unfortunately died in the emergency room. The other point I want to make about those numbers is the whole concept of a transition ward. Our transition ward is where we put patients who have suspected COVID infection, but they are awaiting results. And you know that there has been some delay and backup in getting our results over the last couple of months. Thankfully, things have gotten a lot better, but remember, this data is capturing all patients from March until November. At the time of preparing, on the 27th of November, we had 4 patients in the COVID ICU. 4 were on continuous positive airway pressure support in terms of their breathing, and they were all 4 critical. There were 23 in transition, and which included 2 children, and 7 in the maternity area. So those numbers represent a synopsis of what actually happened, one at a national level and then at the Georgetown Public Hospital level. So we continue to answer questions as they come in from viewers and listeners like yourself. And remember, if you have questions, you may WhatsApp to 620-6275 or send an email to docandcovid@gmail.com. So the question we want to address today that came in from one of our viewers or listeners relates to the use of masks. And here is the question: what are the best masks to wear and how effective are they? And I'm sure that you would have seen masks being worn by persons around you, and you yourselves would have been wearing masks. We have masks that are cloth made, the usual surgical mask that you can see people operating with. There is the KN95 and the N95. Without a doubt, the best, most secure mask to use is the N95. But that is not always available, and it's usually reserved for healthcare workers. I know that there are some civilians or non-healthcare workers who have access to this, and that's good for them. But it is not the usual type of mask available for the general public. And why do we wear a face covering? A face covering stops your germs from reaching others. If you touch the covering, you should wash your hand. Masks do not replace hand washing. You should wash your hands with soap and water regularly. As regards reusable face coverings, remove and wash preferably at 60 degrees and clean your hands with soap and water. The single-use masks you can dispose of in a proper closed container. Now, I know it's a very challenging thing to just change a mask every day or every hour, and especially with limited resources. Masks actually help everyone around you. It doesn't just protect the wearer, but it protects those around the wearer from droplets that may come out of an infected wearer. In terms of the persons who are highest at risk versus those who are lowest at risk, if you look at two groups, one as a carrier and one as an innocent bystander, the highest risk is when no one wears a mask, and the lowest risk is when both persons wear a mask, the carrier as well as the bystander. The low risk is if the carrier wears the mask but the bystander doesn't, and high risk is when the carrier doesn't wear a mask but the bystander wears the mask. It's all a very important concept to understand, that the mask actually protects both persons, but it's more important for the carrier to actually wear the mask. That is the most effective use of the mask. The next thing I want to look at is the evidence behind wearing masks. Does it actually work? Well, let's look at countries that actually made it a policy for masks to be worn in public. And the data is very, very clear. If you look at cases per million, and this is large countries with large populations, in countries that made mask wearing mandatory, such as Taiwan, Thailand, Hong Kong, Japan, those countries had a much lower infection rate per million population versus those countries that did not have enforced mask wearing or mandatory mask wearing. Countries like Spain, Italy, United Kingdom, and Germany. Those countries that did not have mandatory mask wearing had a much higher infection rate than those who put that policy in place. We have that policy in place in Guyana. Unfortunately, enforcement is our biggest challenge for that type of policy. The best times, or the key moments for people to wear their masks, are when they're out in public mainly, or when they are themselves sick but they have to interact with others at home, or when you are caring for or looking after someone who is sick at home. We do not recommend masks to be worn by children under 2 or anyone who has trouble breathing or people who cannot take off their masks without help. And to the point of the effectiveness, well, let us look at some types of masks that we know of. Masks reduce the spread, but it does not eliminate the spread of COVID-19. So it reduces it, but doesn't reduce it to 0. The usual cloth mask can reduce the spread by 10 to 40%. The double-layered fitted cloth mask is almost as effective as the surgical mask. The N95 is the most effective with greater than 95% reduction in infected particles. The only thing that really protects you 100%, we think, is the full hazmat suit from head to toe, basically living in a bubble, which is not really practical. So I hope this would have answered the questions about masks wearing and the effectiveness. Remember, if you have questions, please send us a WhatsApp to 620-6275 or send an email to docandcovid@gmail.com. Thank you once again for joining me today.